Good evening, everyone, and thank you for joining us for tonight's webinar in partnership with St Vincent's NELUNE Men's Health Centre. My name is Ruby Van Cool. I'm the Cancer Prevention and Control Project Officer at Central and Eastern Sydney PHN, and I'm also joined tonight by Bertha Harvey from the CBD team. I'd like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work. We recognise their continuing connection to land, water, and community and pay respect to their elders past, present, and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. I will now introduce our first speaker for this evening, Dr. Jeremy De Leon, a radiation oncologist at Genesis Care, Darlinghurst. Jeremy will speak on non-surgical treatment options for prostate cancer and the important role men's health services play in supporting prostate cancer care.
Great. Thank you, Ruby, for that. Thank you, everyone, for joining us tonight on this talk about prostate cancer in collaboration with the Men's Health Clinic here. My name's Jeremy De Leon. I'm a radiation oncologist at Genesis Care at the St. Vincent's campus. Just a quick rundown of what I'm hoping to cover in the next 15 to 20 minutes. Essentially, just an overview of prostate cancer in New South Wales in terms of the demographics and the numbers that are coming. Indications for radiotherapy, the use of androgen deprivation therapy, which is something a lot of GPs yourselves help look after for patients with, and also advances in radiotherapy technology. So we know that prostate cancer is quite a common disease. It is the most common cancer in men, and according to the Cancer Institute New South Wales Health, it's 1 in 5 men will be diagnosed with prostate cancer. We do know, though, that mortality, thankfully, is fairly low. Only 1 in 44 men actually die from prostate cancer. And a lot of that has got to do with the advances in screening and early detection and treatment. Now, with prostate cancer, not aiming to go into the details and the different grouping stages, we know that radiotherapy can play a role in the treatment of prostate cancer, either the definitive or the curative treatment, or as an adjuvant or a salvage following surgery. In the curative treatment, we know from one of the biggest studies published in the England Journal of Medicine in the low to intermediate risk cancer, that radiotherapy compared to surgery showed the similar outcomes in terms of prostate cancer survival at 15 years and also equal chance of prostate cancer cure. What that means is that radiation is an option. It is not the only option for curing prostate cancer, but it's an option to consider when men are looking at all the potential curative treatments for their low to intermediate prostate cancer. High-risk cancer is a little bit more complicated in the sense we don't have big studies which have told us exactly which way they should be treated. APCCC is an international conference which convenes experts from around the world, and they aim to come up with a consensus on how people with high-risk prostate cancer should be treated. And essentially, they came with no consensus. And I think in that situation, it does require a good discussion with the surgeons, medical oncologists, us radiation oncologists, about the appropriate treatment for men in this grouping. In terms of curative radiotherapy, I think something I wanted to touch on is that we look for the PSA nadir, which is basically the lowest the PSA level gets to. And it can take 12 to 18 months after someone finishes radiotherapy to get there. Now, this nadir is not going to be zero, and it doesn't mean that the patient is not cured. And the simple reason is if we have a gentleman whose PSA started at 7, they had their curative radiotherapy, and 5 years later, their PSA went down, and it's been hovering around 1 to 1.2. We still know from the studies that they have a 95% chance that they are cured of their prostate cancer if they're a low to intermediate grade cancer. But if we were to take a scan of their prostate will look pretty much quite similar. And it's got to do with the fact that it's the preferential death of the prostate cancer cells with the radiation, and a lot of the normal prostate cells do survive radiation, meaning they'll always produce a steady state of PSA, and those cells aren't necessarily cancer cells. So I guess the first take-home message is radiotherapy and surgery offer the same chance of cure of prostate cancer, and it's really about having a a good discussion with your surgeon and radiation oncologist about the best options for your patients. In terms of the number of treatments required to be treated with radiotherapy, the standard is very quickly becoming 20 for a long time, and that was based on studies where previously it used to take up to 33 or even 39 treatments of radiation, and the treatment was 30 minutes of the day. So it was quite a long number of weeks for treatment. That very quickly got replaced by patients only needing 20 treatments, and more recently now 5 treatments has become our standard. And what these graphs are essentially showing, on the left, we see that if you had 39, if you had 40, and if you had 20, your chance of cure was the same. And then the graph on the right is essentially showing if you had 20 treatments versus 5 treatments, again, your chance of cure is exactly the same. So when I think with radiotherapy, a lot more now, it's becoming less visits in for your actual treatment. We do know with radiation, the more radiation you can give, the higher your chance of curing the cancer. And we know one of the ways that this can be done is with a technique called brachytherapy. Essentially, brachytherapy is the delivery of the radiotherapy source directly into the prostate. It is an invasive procedure, but it has, a long history showing excellent outcomes. I guess there's a move in radiation oncology to see, can we emulate the cure rates and the success rates we got with brachytherapy and deliver the same high doses of radiation without having to go through the invasive procedure. And there's been a lot of work looking at this. Specifically, instead of having 2 treatments of brachytherapy, could you have 2 treatments of radiation? And early evidence is showing that we can achieve the same chance of cure without needing the surgical procedure. Even more so now because of the improvements in our imaging with MRIs, PSMA scans, also the ability of the urologist to really get an excellent sample of that prostate, making sure that we get a good idea of where the cancer is and how much cancer is in the prostate, combined with improvements in radiation. What we are doing now is we are giving sort of different doses. We're giving a certain dose to the whole prostate, but we're giving a higher dose to where we know that cancer is. And what we've shown is that that leads to improved outcomes. And also importantly, we know that the chance of having residual cancer in the prostate, if you don't give an extra dose of radiation to that dominant lesion, we call it, or where you know the highest grade of cancer is about 7%. Some quite studied up to 13% with older techniques. But if you're able to now give a higher dose of radiation, especially targeted to where that cancer is in the prostate, we've seen that the chance of having residual cancer is about 2% in the prostate. And we've also seen that you actually get a better outcome. So again, being more targeted, giving a higher dose of radiation to the actual cancer in the prostate, as well as treating the whole prostate, gives a better outcome. So that is what we call boosting the dominant lesion in the prostate. In terms of the areas that we treat, as we talked about, for low and intermediate risk cancers, we often just have to treat the prostate. But there are subsets of patients where we know they have a risk of having disease within the pelvic lymph nodes. And this may even be individuals who on all their imaging doesn't show any obvious cancer in the pelvic lymph nodes, but they have an aggressive cancer in the prostate. We know there's a high chance they have microscopic disease in there. So in these situations, oftentimes we do need to treat the pelvic lymph nodes with radiotherapy, and this could be in the curative setting or it could be after surgery. It's about selecting the appropriate patient and knowing exactly who we need to cover. But as you can see, the area that we cover is quite extensive. It goes out of the sacrum up to the top of L5, and we cover all those lymph nodes all the way down the pelvis on both sides. Radiotherapy techniques have evolved so that we're able to scope the radiotherapy dose around these areas. So what you're seeing here is essentially slices of a specific patient. We've outlined the areas we wanted to treat, which are in red, and the blue is where we're aiming the high doses of our radiotherapy. That red spot you can see on that patient's left was an area where we knew there was a positive lymph node. And again, it's about delivering a slightly higher dose to where we can see that actual disease. So we know that treating lymph nodes in the pelvis is used in certain situations, especially in high-risk disease. Now, there's always the concern with any treatment, and especially with radiotherapy, 5 years, 10 years, even 15 years after, we're going to have troubles with peeing out blood, or you're going to have issues with your bowels and your rectum. And there's no doubt, 15, even probably 15 or 20 years ago, this is how radiotherapy was delivered. Um, there was no real ability to finesse, and we was basically using just radiotherapy from four directions, meaning that we treated quite a large area. But that is now contrasted to today, where our radiotherapy doses, based on the technique, are a lot more conformal, shaping around the prostate, really aiming to reduce the amount of radiation to the normal organs. But no treatment, no radiotherapy is without potential risks. And we've seen in a lot of the studies that at about 10 years, 10% of people will report moderate urinary symptoms after radiation. Um, and in terms of bowels, which used to be the highest concern of patients following radiation treatment, that was about 7.5%. And I think the biggest change, which is mean that we're not getting as many bowel symptoms, is the use of rectal spacing. So what we can see here in the picture below is essentially sort of a transverse slice of a patient there. You can see their prostate and the rectum. The rectum is the thing with the sort of dark thing in the middle. And the image in the middle is where some gel is put in between. And this gel is often placed by our urology colleagues who are able to really get a nice plane, a nice separation. So what that means is we can focus a lot more radiation on that prostate, and the amount of radiation going to the rectum reduces quite dramatically. So instead of seeing, 7.5, 10% risk of bowel side effects, that definitely has reduced substantially. But I do say, even though we are moving more to these five fraction courses of treatment, we do know that there's a slightly higher risk of side effects, and something that we do see and then your patients may experience on this graph here, especially the one on the left. The dotted line is where we use stereotactic radiation, or 5 treatments of radiation. The blue line is where we've used 20 treatments of radiation. We can see at about that 9 to 18-month mark, there's an increase in urinary side effects with radiotherapy. We do see that at about the 2 year mark, it then settles down, but that what we call symptom flare does happen in about 1 in 4 patients. It does often require some sort of management, and that could be medications or requiring a cystoscopy to ensure that there's nothing else going on in there, but it is something to be aware of. But overall, we can see long-term radiotherapy is very well tolerated, especially with the advances in techniques that we're using. Just quickly about androgen deprivation therapy. So the concept behind this is that it's blocking testosterone, and we know that radiotherapy feeds off testosterone. So the concept is by blocking testosterone, we block prostate cancer of its food. It will kill prostate cancer cells, but we also know it on its own will not cure prostate cancer, because there'll become a point in time where there will be cells which do not respond to the injections. We often use this a lot more in our higher risk patients, so patients with slightly more aggressive disease, and we know it improves their overall survival, regardless of what type of radiation we deliver. Even if we give higher doses of radiation to the tumor, we still know there is a benefit of anti-hormones. I guess in the lower intermediate risk group, I guess it's still not as sure about who benefits. A lot of our data is based on good quality evidence, but what's becoming more and more used now is a lot more, I guess, added information, which is telling us more concretely who benefits. And one of those available is something called the Arteria AI test, which essentially just requires a picture of the patient's biopsy that is done as part of the standard workup. And it then gives you an actual score of what their benefit will be of being on anti-hormones, and also would it be recommended in that case. And I think that really allows us to tailor our treatment, because we all know that anti-hormones can cause significant side effects in our patients. And patients that have to be on it, it's really important that we address these. And that's something that's really important part of men's health. So exercise, psychology, dietitian, all of that is so important on men that are on anti-hormones. Um, so I think anti-hormones have an important role, but it's really exciting to see we got more advanced testing, which is telling us a bit more concretely who actually derives the benefits. In terms of advanced technology in the last 2 or 3 minutes of my talk, I guess radiation, the concept behind it for a long time is that they get a CT scan a couple of days before they start. Um, then we use that scan to plan their treatment, outlining the area we want to treat. We come up with the radiotherapy plan, which essentially is how the X-ray beams come in, and we can tell how much the prostate's getting, how much the bladder's getting, how much the rectum's getting. Everything ticks the box. And then that becomes the blueprint. And then every day we use the same blueprint on that patient. Now, we know it works. That's how we got our 95% chance of cure, and especially in that low and intermediate risk. But we also know there are some days where that blueprint created a week or two ago is not the perfect blueprint for that day. And we can see here in this example, this individual, it's more so their bladder and rectum did change slightly, but we weren't able to make any changes based on that. What's more ideal is this idea of adaptive treatment, whereby every time that patient lies down on the bed, we take a scan, we take an image, and we work out then and there what's the best way to treat that patient. How is the radiation going to come in? Are those organs actually getting? So in a sense, instead of one blueprint, patients are getting five blueprints because every single time they come in, it's a brand new treatment based on their changes in anatomy. Um, at St. Vincent's, we're quite lucky and fortunate that we have two machines that can deliver it. One is the MRI Linac, which combines MRI imaging with the ability to do what I was talking about. And more recently, we've installed a new CT guided system, and we'll be the first in Australia to launch that next year with this adaptive capabilities as well. The other part of these treatments, and this is an example of an MRI treatment, is we monitor the patient while they're actually having the radiation delivered. And you can see in this case, while the X-ray beam was turned on, the individual did pass some gas and it actually moved the prostate out of the way. So being able to see this, being able to correct for it, turn the X-ray beam off until everything is settled down and turn it back on, it means we can be more accurate in the actual treatment. Um, what we know with MRI guided treatment is that, I wouldn't say it has, thousands and thousands of papers to say it's superior to traditional treatment. Early studies are starting to come out now, which are showing a halving of side effects and toxicity, which I think will lead to lower rates of long-term toxicity. But again, this is yet to be shown in the studies. What we see here in this diagram is an individual where we treated after a radical prostatectomy, and that area is actually a space. There's not actually a mass that we're treating when we give radiation in those situations. And that space is defined by the bladder and the rectum. So if you can imagine, the bladder and the rectum are changing every day, so that space changes every day. So this is where something like an MRI, LINAC, or a CT-based adaptive treatment would really give us benefit being accurate in our treatment. It's also about being sure that we know what we want to see. At the top there is a patient CT, and at the bottom is their MRI. They have a very small area of recurrence. This was about 12 to 13 years after their surgery. We couldn't see on the CT, could see it quite nicely in the MRI, and it meant we could just target that area. So it's about, really being focused with our treatment. So I think the last point there is adaptive radiotherapy changes the treatment as anatomy changes. So it's about being a lot more accurate with our treatment. But with all of this, especially in radiation treatment, the important thing that often gets missed and is important about the men's health clinic is the holistic care. It's about having everyone involved in that patient's treatment. It's having our surgical colleagues, having our medical oncology colleagues, it's having our physios, having our nurse navigators, social workers, dietitians, um, and psychologists. All of that means that we're looking after the patient, not just their prostate cancer alone, but the patient as a whole. And I think that definitely changes patients' outcome from not just a physical standpoint, but also importantly, a mental and psychological standpoint. Thank you for your time today.
Thanks, Jeremy, and thanks for those take-home messages as well. It doesn't look like there's any questions at the moment, but if anyone does have questions, you can use the Q&A box down the bottom, and we can get to those at the end of the presentations as well. So I'll introduce our next speaker, who is Dr. David Endy, a urologist from St Vincent's Hospital, Sydney. In this session, he'll be covering the surgical treatment of prostate cancer and ways to support men through their prostate cancer journey. Thanks, David.
Thank you for that. I'm now screen sharing.
Yeah, that looks good.
Good. Okay. Thanks, Jeremy. So my brief was to talk about advances in surgery. I'll come to that in a minute. There's not a lot of advances in surgery, but there's a little bit of advance in robot technology. But I wanted to talk a bit about focal therapy, which is definitely a new treatment. And I thought I'd also give a bit of an update on PSA because the new guidelines are coming out shortly. So I thought I would just introduce those. I also noticed that on my brief that I read a few days ago, that we were also talking about the Men's Health Centre and the supportive care. But really, that we'll come to that a bit later because, as Jeremy said, this is really a team approach from the Men's Health Centre, where all of the aspects of care for prostate cancer, no matter what modality they had for treatment, everything is available in the one location, and it's an excellent resource. Our patients love it. But we will obviously hear more about that toward the end. In terms of the clinicians' patient support, I think there's just a few things to cover. And I mean, these are all a little bit self-evident, but it's a really long journey for the patient from the time they come in, with potentially possibly having a cancer in their prostate with a high PSA, and then going through to a year or two after treatment. I think there's just a few things that any clinician should be helping the patient with. And I think one is to give them accurate and relevant information. They really just need facts and discussions about that. I think they really do need honest advice, particularly in something like prostate cancer, where there really are several ways that they can be treated and managed. Some patients don't even need treatment for prostate cancer. And I think you just have to cover all of this very carefully. One thing that I always tell patients is that it's rarely urgent that a patient needs treatment for prostate cancer. So they've got plenty of time and they need time to think about the various options, and all alternatives have to be given to the patient. As Jeremy mentioned, radiation and surgery for most of prostate cancer patients, the outcome is similar, and it really just comes down to their personal choice and potentially what side effects they want to accept. So you really just have to be very patient. And then last of all, we should all be referring everyone to the Men's Health Centre because the services that they provide are excellent, and the patients really do get a comprehensive viewpoint of their treatment. So I'll just move on. So I was just going to talk a little bit about surgery, not so much the actual surgery, but this is a picture here on the left of what we call the multi-port robot. And you can see that this is the robot component with the arms. There's 4 arms there. And when the patient is in position, there are 4 cannulas that go into the body, so there's 1, 2, 3, 4, and there's an assistant port here and another assistant port here. So in effect, there are 6 small laparoscopic incision sites. The new kid on the block is the single port robot, which St. Vincent's is in the process of acquiring, I think. So essentially, it's just a single port, which is this one here on the arm of the robot. And you can see through that port are 3 instruments and the camera with the light. So the surgeon controls all these 3 instruments, and it's a much more confined space, but obviously the implications for the patient are a little bit different. So a single incision is made, and this is like a wound protector, and this is an adapter for the port. And then this is the port that attaches to that adapter, and the robot arm will attach to that, and some instruments can go through here as well for the assistant. So you can pass a sucker and any other type of instrument to assist through there. On the inside, it's a bit hard to tell. I didn't want to sort of bore you with too many videos of surgery. I'll show you one just because it's nice to see. But you can see the instruments here are all in quite close proximity. This is the prostate here. That's a catheter going through the middle, and the bladder is at the bottom here. So it's all in very close proximity. As you can see again here, that's now we've cut through the bladder neck. These are your 3 instrument arms, and this is the catheter again, lifting the prostate up. And just a short video, just because it always looks good. This is a multi-port one, and you can see that you've actually got much more, a much bigger access. The single port robot goes through the extraperitoneal space, whereas the multi-port goes through the peritoneal cavity. So you've got much more space. These are the pelvic side walls here. This is the pelvic floor here. This is the prostate, bladder up here, and we're coming across the bladder neck here. And so I'll just show this for a minute or two because there's not a lot of time. This is opening up through into at the bladder neck. So you can see that's where the catheter's coming out through there, lifting the prostate up. So it's always good to see robotic surgery, but you basically can see the field of view here is much larger, as with the single port, it's closer, but the surgery is essentially similar. So we'll just move on there. This is a single port, just showing a few more photos. That's the urethra there, and this is the bladder here. The prostate's been removed, and this is a suture to anastomose the urethra to the bladder. And this is removing the specimen is on the end of that suture there in a bag. This is removing the port site, and you end up with just a single incision there. Whereas with the previous multi-port, there were 6 incisions across here. Each one of those incisions goes through a muscle belly, so it's a little bit more painful afterwards. This is a midline incision. So it's a single incision. It's a bit less painful because it's a midline incision, so not really cutting through muscle. It's extraperitoneal, as I say, so the recovery is generally quicker. Patients overseas, we had a speaker come out recently who was telling us that in the United States, they send patients home on the same day, which is a bit hard to imagine, but that's what they do. It is a new learning curve because it's slightly different technology because the space is smaller. But essentially, that's a little bit of what's new in robotic surgery. I did want to spend a bit more time speaking about focal therapy because this will be becoming a new standard treatment. It's currently still said to be under as an experimental treatment under investigation. I just have to say I have to thank Professor Stricker for these slides. A lot of these slides are derived from him. He's been doing the most work in this country, and Daniel Feng, who's the fellow who also helped me put these slides together. But essentially, focal therapy it treats just the lesion within the prostate. The prostate stays in situ and the lesion is treated. There are specific criteria to select the patients. There's very few side effects. You can retreat a patient if the cancer is said to recur, and it doesn't burn any bridges, focal therapy, so you can still have salvage therapy with surgery or radiotherapy if the cancer recurs. So essentially, if you have a tumor here, which you can see on the MRI, and then with your targeted biopsies, you confirm that. And with a PSMA nuclear scan, you can just ablate the tumor with the zone around it and leave the remainder of the prostate intact. You can cover 2 adjacent tumors in different quadrants, anterior tumors. So it's quite versatile in treating focal lesions. Patients really need to decide about cancer control, but they want to maintain urinary control and they generally want to maintain sexual function. So focal therapy really does enable that. For the low risk cancers, we generally put those patients on active surveillance. They would very rarely get treatment. They remain on an active surveillance program for some time with careful monitoring. The higher risk patients, they generally need what we call whole gland treatment. with whether that's surgery or radiotherapy. Those are for higher risk cases. And then there's this intermediate group where in the green here, there's a bit of overlap with high grade, but essentially these patients are suitable for focal therapy. If their cancer occurs, they can go on to later whole gland treatment if required. So essentially, ideal patients for this are patients who have not insignificant cancers because they would be on active surveillance. It's usually patients in the grade group 2, Gleason 3+4, mainly pattern 3, but some pattern 4 with a good prognosis. It can be localized. You can have unilateral. That's how the treatment works. They need to have a transperineal biopsy. They need good MRI and subsequent PSMA. You need to be able to see the lesions on both of those. And you'll see a few pictures later. And the biopsy and the imaging need to be co-registered. So you have to be able to confirm that the tumor is actually where the lesion was identified on the imaging. One of the things about focal therapy, and maybe it's a bit aggressive at the moment because it's still being evaluated, but there's quite intensive follow-up, and I'll show you that a bit later, but they need much more regular PSA testing and follow-up MRI scans and biopsies to confirm that the tumor has been treated. But they get good preservation of genitourinary function. It's only been around for maybe 10 years or so, so there is still some uncertainties with regard to long-term follow-up, but it seems to be very good so far, and you may need salvage treatment. It's quite simple to do focal therapy, and it's quite a reliable treatment with a reliable outcome. You can broaden the field of treatment as you saw in those pictures. There's good functional outcomes and oncologic cure rates. You can use it in the primary. You can also use it in salvage settings. So following patients with radiotherapy, if they do get a recurrence, you can do focal therapy with a low risk of side effects. You can repeat focal therapy if the cancer occurs. It's relatively easy to learn. And a very important factor is that it preserves tubular structures, so the urethra and nerves are not damaged by the treatment. So very basically, the way it works is that you target your cells. Focal therapy in this sense is irreversible electroporation. So basically, you are passing an electrical current through the tumor, which destroys the cells by inducing apoptosis, and you get holes in the cell membrane, and then the cells are phagocytosed and removed. So that's very basically how it works. The way it's delivered is very similar to the way we do a biopsy, which is why it's a very familiar thing for most urologists to pick up, because this is the ultrasound probe here in the cradle, and this is the template, the grid we use or for some people use a grid like this to pass needles through here to fire them into the prostate. You put 4 or 5 or 6 of the needles surrounding the tumor, and then you can pass the current. You do need an anesthetic. You need muscle relaxant to give the treatment. So it is suitable for virtually anywhere in the prostate. If there's calcification in the prostate, that doesn't seem to affect it. You can treat tumors that are very close to the urethra. You can have treatment just outside the capsule. So if there is some extracapsular extension, you can generally still treat that. And because it's not thermal, it doesn't necessarily affect erections as much as other forms of energy. So just to show again, you can treat just standard peripheral tumors in the peripheral zone, anterior tumors that are close to the urethra, quite large, high anterior tumors that you can treat at the apex if there's calcification in the prostate, and if the tumor is close to the prostate, you can still treat that without necessarily affecting the neurovascular bundle that's just on the edge of the prostate. This slide just shows that the way the treatment works, it doesn't damage tubular structures. So that's mainly the urethra. You can treat close to the urethra, but also nerves and the vessels in the prostate, which is a big advantage. So it's a little bit hard to see on these screens here, but these points, this is the artifact from the needles, but you can see each point. Whoop, let's go back there. Each point here is where a needle has gone through this transverse image. So the tumor is in here, and it's basically surrounded by the probes. And as you can see, you can have a box, or you can have a box with a triangle, and electrical current is passed through each probe in turn, and that creates the zone of tumor killing in the middle there. Post-operatively, the patients, you need local anaesthetic, and they have a catheter in for a few days. It's a day surgery procedure. They don't get a lot of discomfort from it. They need to go home with the catheter, as I say, and they can come back within a few days to have the catheter removed. They get some pain and some anticholinergics because patients generally get some bladder spasms, and they get alpha blockers to reduce swelling of the prostate and to help them void, and some antibiotics, and they get a bit of hematuria, but generally it's tolerated very well. As I mentioned before, the follow-up is a little bit onerous. They need a PSA every 3 months for a year. They need a proper multiparametric MRI after 6 months, and we do a limited MRI after a few days just to check that the prostate is, the tumor looks like it's been treated. They fill out quality of life forms every 6 months, and then they get another, they should be getting because it's still in early days and being evaluated, they get a systemic transperineal biopsy at 1 year to make sure that there's no residual cancer. That may or may not persist depending on how well the treatment pans out over the years. In terms of cure, early on there was about a recurrence rate of 9.7 in the tumour field, and out of the tumour field there was a slightly higher rate of recurrence, but with the procedure being modified, that in-field recurrence has dropped significantly. There was an increased margin of ablation around the lesions, so the recurrence rate is really quite low, 2.7% there. This slide indicates that after treatment, 84% of the patients in this particular trial did not need any radical follow-up radical treatment afterwards, either with radiotherapy or surgery. Of the ones who did, 28 had radical prostatectomy and 10 had radiotherapy, 1 had ADT. So the overall cure rates are very high, and the metastasis-free survival was almost 100%. These outcomes aren't particularly long because the technology hasn't been around for all that long. In terms of functional outcomes, the continence rate is very high. There's a very low percentage of significant incontinence. Erectile function is around 60 to 70% up to about 2 years, which is good. And there were no significant complications. In particular, when you talk about focal therapy, the other techniques are radiation and HIFU. They all had a risk of rectal fistulas, but with focal therapy, there haven't been any rectal fistulas. In terms of, these are the other forms of focal therapy: HIFU, cryoablation, laser is a new technique as well. With our focal therapy, the electroporation, the cancer rate after ablation is very low. The recurrence rate is only 8.5%. So it seems to be better than a lot of the competing energy sources. Using this focal therapy after radiation is possible. You can see that after radiotherapy, if there is recurrent cancer, you could have salvage radical prostatectomy or some of the other forms of follow-up. With IRE, the cure rates are higher than in the other groups, and the complication rates are lower. So it seems to be a very good way of salvaging radiotherapy without getting significant complications. So from that point of view, that would be another use for this. So just to conclude about focal therapy, it's safe. You can use it for tumors all around the prostate. You do need a lot of follow-up, but particularly in these early years because it's a relatively new modality, but that does require imaging and biopsies, and patients have to be aware of that. It's a reliable source of treatment, of providing the energy, and there are good outcomes. It's relatively quick. It's easy to replicate. There's less collateral damage with this type of technology, but we do need to be very careful about who we select. So that's something. It's still in the experimental stage. It's not approval for through the TGA and through for Medicare rebates is being sought now. It's not yet available freely, but it hopefully will be not too far away. So I thought I would also talk a little bit about PSA and the new guidelines, just because there was a whole review of PSA screening and new guidelines are about to come out, I think, toward the end of the year. So I thought I would just go through some of those and just reinforce the way we think about this. High-risk patients if you have a brother diagnosed with prostate cancer or a father, so a first-degree relative, but in terms of your father, it's significant if the father was diagnosed under the age of 65. Prostate cancer is so common in elderly men that if your father was diagnosed, in his 80s, that's probably not such a significant risk factor for you, but at a younger age, it's much more significant. And if you have two or more second-degree relatives, so cousins or grandfather who died of cancer, that also puts you in a higher risk group. And if you're in one of these groups, your risk of dying is at least double that of the non-high risk patients or men. High risk men are also men, obviously, who are diagnosed with BRCA2 mutation, but also more recently added to this high risk group are some of the familial syndromes. So Lynch syndrome also includes men with prostate cancer. Also with hereditary breast and ovarian cancer would put you at an increased risk. So in terms of digital rectal examination, it's not the recommendation will be that it's not necessarily routine for the GPs to provide it, but if a patient wants to have a discussion and wants to be investigated for prostate cancer, it would be something that the urologist would need to do. And I think the frequency of DREs is probably less than it used to be, but you certainly do need to do it at least on presentation and depending on whether the PSA changes over the years. I think in my experience, digital rectal examinations, they're obviously normal or they're obviously abnormal, but many are equivocal and prostates can feel firm or indurated, and it's quite difficult to be dogmatic about how a prostate feels in many cases, and that's why we have to use other information such as the PSA and family history in terms of further investigations. So within the general population, men 50 to 69 the recommendation would be to have PSA testing every 2 years. And if the PSA is greater than 3 and you repeat it and it's still greater than 3, they should be offered further investigation. Whether or not you go on and do an MRI would depend on other factors. For me, I think what's really important and interesting is the younger men who get tested. It's very hard to know what a normal PSA is for a man who's 43 or 45 or 48 because a lot of those men were never really tested before, and we are seeing more and more of those men have PSAs. But it's good to note if their PSA is less than 1, their risk of prostate cancer is very low and they don't need further testing at least until they're 50. So that takes them out of the equation at that point. If you have high risk men, they can be tested every couple of years from the age of 40. And if their PSA is over 1 in this high risk group, they can have further investigations and referral to a urologist to discuss whether or not they would go on and have an MRI after that. And for high risk men in 50 to 69, if their PSA is over 2, then they should be considered for further investigation, which would normally be with an MRI. PSA testing for men, it's always difficult in the older age group, and we'd like them to have an life expectancy of at least 7 years to derive the benefit from diagnosing a cancer. Men over 70, a PSA every couple of years, depending on their overall fitness and their willingness to undergo investigations and potential treatment. And if their PSA is over 5.5, they would need further investigation. But again, it really depends on their age specifically, and I'll come to that in a little bit, how to make the PSA a bit more useful. So if a man has a PSA that's suspicious, the next step for them is an MRI, which is fairly standard at the current time, and that will determine whether or not a biopsy is necessary. Obviously, any man who's got an abnormal MRI with the PIRADS 4 or 5, they would be directed toward biopsy. A PIRADS 3 lesion on MRI is said to have about a 50-50 chance of having cancer, but it's still a bit controversial. But I think you can have extra guidance by using the PSA density. So if the PSA density is high, which basically means they've got a high PSA relative to the size of their prostate, then with a PIRADS 3 lesion, I think they should be treated. The patients who have a negative MRI is a difficult group because they obviously would still have an abnormal PSA, or they would have an abnormal feeling prostate, and their MRI comes back normal. We know MRIs miss a very small number of cancers, and I think that I would still talk to them about a biopsy, especially if they hadn't had one before. But I think it's reasonable to either repeat their PSA and see if it remains elevated, and if it did, I would then discuss biopsy. And I think what's becoming more common these days is that in that situation, it's worth doing a PSMA scan, even though that's not a PBS funded imaging technique. If the PSMA was positive in those men, I think you could use that to guide a biopsy. And I think that's becoming more and more common. So just to end up in the PSA it's often very difficult to interpret the way PSAs fluctuate, and men often get very anxious with their PSA goes up from 4.8 to 5.1, and whether that's significant or not. And I think there are ways to make the PSA a little bit more useful, to look at the PSA density, so relative to the size of their prostate. The free to total ratio is good. It's not the be all and end all, but it definitely is useful. It really does relate, I think, to the size of their prostate, but if it's very low or very high, then it gives you a bit more information. Age related, I think, normal PSA obviously for a 50-year-old is probably in the order of about 2, whereas for an 80-year-old, it's probably closer to 8. And so you can use that quite easily. And then what's really important is the rate of change of the PSA. So if a PSA goes from 1 to 3 in any age man, that would be significant, and they would generally require further investigation, even though at a PSA of 3, that might be very low for their age group. So these discussions are often very protracted. Patients often ask a lot of questions about minor changes in their PSA, or does it mean I have cancer or don't have cancer? And I think you just have to spend the time and go through it with them and come up with an acceptable plan. So I think that's my last slide. Yes. So I'm sorry if I went a bit over time. I'm not sure if I did, but that's it for me.
Thanks, David. No, you're right. And we've got some questions, and we've got a bit of time for questions. So I might leave the first one for the end of the presentation, but the next one is, as I understand, MRI cannot differentiate between mild and low cancer, especially in central and transitional prostate cancer. How do you decide between active surveillance and focal therapy?
Sorry, based on it would be based on the biopsy result. So I think I think regardless of the findings on MRI and probably even PSMA, I think if the biopsy, if you're happy that you've done a good biopsy and it's thorough and you haven't missed the target lesion, if the cancer was low grade and suitable for surveillance, I would base it on that. If I was very anxious that I might have missed more high grade cancer, which you can't really know, I would watch their PSA very carefully, and I might do it earlier than I would otherwise. And I might even repeat the imaging if I thought I'd missed something. But I think you basically have to go on your biopsy result rather than imaging.
Thanks. And are there different focal therapies depending on cancer location in the prostate?
There are different focal therapies, as I mentioned. There's laser and HIFU. But I think the problem with some of them is if they're close to the urethra, you really want to avoid urethral damage. And if they are very close to the edge of the prostate, you want to avoid damage to the neurovascular bundle, which is why Phil Stricker, Professor Stricker has taken up the irreversible electroporation, because the side effects are much less harmful for those structures like the urethra and the neurovascular bundle. But if you can reach it with your probes, then you can treat it essentially.
Thank you. And does free PSA ratio on second testing, for example, less than 25%, play a role?
I think you mean on a second PSA test. I think the free to total ratio, I think, is, for me, it's sort of a secondary, maybe comforting, maybe uncomforting number. I generally would go by the total PSA. That would make me make my decisions. It's certainly reassuring if the free to total ratio is very high. I think if the free to total ratio is less than 10%, I'm more swayed towards thinking that there's a significant cancer. And if the if the free to total ratio is higher than 20 or 25%, I'm less inclined to think it's a significant cancer. But I would still base my investigations on the total PSA and those other things, the PSA change, the velocity, the density, those sorts of things.
Thank you. And do you have any idea of the cost of PSMA to patients?
PSMA is funded if they have a diagnosis of cancer. When I mentioned it in my talk, that was for men who haven't had haven't had a cancer diagnosed, but we like to use it to help diagnose, to see if there is avidity in the prostate. My understanding, it's in the order of about $800 or so. Jeremy might see them as well, but I think it's about that mark, 800, 1,000, something like that.
I agree with David. It is about that much for an unfunded PSMA.
Thank you.
And Jeremy, do you worry a lot about the free to total ratio, or really look at the total PSA?
I guess a lot of the times we see that they've already been diagnosed with prostate cancer, but they will be looking mainly at the total PSA.
Yeah, I think we do the same.
Thank you. So we might move on to the next session, but there are a few questions in the Q&A, if you wouldn't mind having a look, David, and seeing if you can answer some of those while we keep going.
See. Yeah.
Yeah.
Sure.
Thank you. So in this final session, we'll be hearing from a range of experts from the St. Vincent's Men's Health Centre, who will share insights on the physical, psychological, and social impacts of prostate cancer, along with strategies to support patients. So I'll just ask that each of the speakers just introduce themselves at the start of their session. Thanks.
Thank you, Ruby. My name is Cami. I'm the Men's Health Center Manager. So today, unfortunately, our prostate cancer nurse, Russell, was not available to present his slides. So I will present that on behalf of him. And also before we start, so Russells have two main roles. One part is to look after sexual functions of the prostate cancer patients. Another part is mainly to support providing information and reassurance about all different kinds of prostate cancer treatment. We do find that the majority of patients, when they first get referred to us by the GP, often they find quite overwhelmed and unsure about treatment decisions making. So that's where one of his main role is to help patients to understand different treatment and their pros and cons, and also potential complications. So let me share my screen. Okay, so today I'm going to quickly talk about managing sexual functions after prostate cancer treatment. So the principle of penile rehab, what we want is actually see the patients at the time of once they decide, what treatment that they choose to have, whether it would be prostatectomy or radiation therapy, for later stage ADT or any other treatments. So we want to see them from a prehab point where the prostate cancer nurse and the men's health physio will provide information and assess the baseline for the penile prehab and rehab. So what we want to achieve is to promote the blood flow back to the corpora cavernosa. Interventions can be both used for rehab or sexual activity. The main thing is we will assess what is their baseline erectile functions first, and the goal will be to return their baseline erectile functions after the treatment. As previously, David and Jeremy do mention, sexual health is more than just a physical functions, psychological impact, emotional, and sometimes social issue also impacting on their sexual functions, which why we have the whole team to support patients, not just before, after, but from the point of they diagnosed with prostate cancer. So what we do in terms of intervention, there are four elements that we can provide. One is through medications. Those are PBS subsidized, so often it's quite affordable to patients. And next thing will be the medical grade pump. So those pump, the private health insurance normally can provide some subsidies. Otherwise, on average, it's around $300 per devices. Another option which our prostate cancer nurse Russell also provide is a ICI therapy. So with Carver-Jack, what our prostate cancer nurse do is to provide training. They will assist and help the patient in terms of administering the injections. And should all the other three treatment options unsuccessful, then the last options will be a permanent surgical implant. Recently, I've attended a prostate cancer conference where in Melbourne, they also, start to talk about a implant for stimulator, so more targeting with a permanent, solution. But that's rather new technology. Maybe later on, we'll see more research evidence on that. Management of the sexual functions, as I said earlier on, what we want is we actually want to see them as soon as they diagnose. Sometimes we get referral at the point of diagnosis. Sometimes we get referral from specialists once they decide their treatment. We will also talk about assessment on comorbidity that affect erectile functions, for example, obesity, any caffeine, alcohol intake as well. Lifestyle factor also affect erectile functions and their age. Then once we've done the assessment, we'll provide education counseling. penile rehab treatment options, as we discussed in the earlier slide, and also understanding side effect and impact of each treatment. We've gone through the treatment options earlier on, and the management will be continue to follow up with the patients. We assess how they respond to the treatment, and so that treatment can be sometimes they can have a return of spontaneous reaction erection as well. And that's it from me. So I'll leave it. So next, our next presenter, Luke, I'll let you introduce yourself.
My name's Luke. I'm a men's health physiotherapist at the Men's Health Centre. So I'll be talking about the impact of prostate cancer on urinary function and strategies for management. So firstly, I'll talk about the urinary side effects from prostatectomy. You can see from this sort of flow chart here that most people experience some degree of incontinence after the removal of a catheter. Sometimes up to 20% can experience continence from after catheter removal, but you can see over the course of the year that most people gradually regain continence. At 2 or 3 months these days, up to 80% can regain continence. Can be up to 9% at 12 months that still experience some degree of incontinence. The statistics are quite varied because it often depends on how they define continence. Some studies define it as 1 pad a day and some define it as no pads, so that's why the numbers are quite varied. You can move on to the next slide there, Cami. So you can see that there's certain factors influence incontinence after a prostatectomy. You can see the words in white outline the non-modifiable risk factors. So I'll talk about a couple of those. Age, once you're over 75, people tend to recover slower, but you do get some healthier 75-year-olds. Membranous urethral length, once that gets above 1.2 centimeters, people tend to have faster improvements of their incontinence or achieve continence sooner. And that's the length of the urethra from the base of the prostate to the start of the penile bulb. There's a whole bunch of other non-modifiable risk factors, but the words in yellow indicate the modifiable risk factors, so that something that the patient does have control over to improve their outcome. So their pelvic floor muscle strength preoperatively can help to improve or mitigate the side effects of urinary incontinence after a prostatectomy. And we'll touch more on that in a second. Also, people's BMI. So if their BMI is over 30, they tend to have an increased risk of ongoing incontinence. So part of the management strategies involve, if we can see them early enough, to manage the weight as well. Moving on to the next slide. So you can see from this study here, for every stage of the recovery, the intervention group, which was the group that were undergoing preoperatively pelvic floor muscle training, had less of the population that were incontinent, which highlights the importance of preoperative physiotherapy. And the next slide, you can see also that that's graphed here, showing that the intervention group had a 36% reduced risk of post-op incontinence at 3 months post-op, and significant improvements in quality of life scores at 3 and 6 months. So then, in addition to the pelvic floor training, there are a few other strategies we can implement to improve patient outcomes and reduce side effects. But the priority is to teach them pelvic floor exercises just because of the research backing behind it, and bladder retraining if the patient is experiencing any sort of frequency or urgency. We do this by performing a transperineal ultrasound, and this gives the patient the biofeedback to be able to learn how to do these exercises accurately. And some of them actually respond really well to that, and it just improves their motor control quite significantly. So we do that as much as we can. If we can get them early enough to manage their weight, so sometimes that requires a few more weeks, maybe 6 to 8 weeks. We can have a bit of an effect on that. Post-operatively, we need to build their pelvic floor control and strength, and also improve their pelvic floor timing to gain control over some stress incontinence that they may experience. Again, bladder retraining, more for the guys that experience increased frequency and urgency. Most of those have that symptom pre-surgery. Lifestyle modifications, including fluid and exercise modification as well. And then building up the patient's conditioning to return them to a pre-surgery, to their pre-surgery activity levels is also really important. If the patient doesn't achieve continence, we do refer back to urologists to consider surgical interventions, especially if it's quite bothersome. All right, we'll move on to talking about the urinary side effects from radiotherapy. And you can see from this picture here that most prevalent urinary side effect is frequency and urgency of urinating. If this is developed post-radiotherapy, most of the time this is resolved within, or this can be resolved within 18 months if you know, they didn't do anything at all. But the pelvic floor training and bladder retraining strategies can help accelerate that. There's less likely risk of any urinary incontinence from radiotherapy. It tends to be more the people who go into radiotherapy with pre-existing urinary incontinence, possibly from previous treatments, including prostatectomies, that contribute most to that statistic you can see there. Moving on to the next slide. So like a prostatectomy, there can be certain risk factors that can influence a person experiencing urinary side effects after radiotherapy. So pre-existing symptoms like I've just discussed. If people don't regain continence after prostatectomy, they tend to find it really difficult to then overcome that and achieve continence following radiotherapy, just due to scarring and irritation of some of the structures. There is some emerging evidence for preparing patients for radiotherapy. This may help patients to manage their urinary frequency and urgency earlier before certain habits may form and exacerbate things. So we tend to focus on building up their pelvic floor muscle training to apply that to some of those bladder retraining strategies and urge suppression techniques to improve bladder storage. Sometimes needs the assistance of some medications to help get that under control. And again, lifestyle modifications, including modifying fluid intake and exercise, but mainly the interventions or the management strategies are bladder retraining due to the most prevalent side effects being frequency and urgency. Education's still pretty important though, just to set expectations for the patients too. So they know what to look out for and better manage their symptoms as well. And that's it from me. So I guess the main take-home message is that physiotherapy helps to mitigate the side effects from treatment, and it also helps to really empower the patients to have some degree of control over their outcomes. I think we have Douglas up next. I'll let him introduce himself.
Yeah, evening everyone. Douglas, or Doug here. I'm clinical psychology registrar working through the Men's Health Centre. So just quickly, what we're talking about here at the highest level, we're looking at cancer as a psychological stressor. So anything that your patients are walking in the door with in terms of unhealthy stress responses, we would want to be paying attention to. This could be as diverse as substance use, relationship difficulties, unhealthy eating, but there's a sort of common list of really core treatment-specific processes that we're also looking at here. Primarily anxiety and depression, pretty common here. So you can see there that sort of post-diagnosis, we can have about 20%, other cancers, it can be up to sort of 40% of people experiencing depression and or anxiety. This can either be an exacerbation of depression prior to diagnosis, or can be novel depression for people. What I want to highlight here is the impact of psychological conditions on treatment compliance. So there's some evidence that rates of non-adherence to treatment can be up to sort of 3 times higher in people with depression than those without. That's both the kind of obvious, maybe there's some hopelessness there. What's the point of continuing but also just lack of ability to get out of bed in the morning, lack of motivation really affecting the ability to attend appointments. The other obvious kind of pathway we've got here that really affects adherence is anxiety. So this is both in the sort of constant reassurance seeking presentation where someone's going to be overutilizing services, especially with you guys in primary care, really reaching out all the time, maybe particularly in the context of PSA monitoring or something like that, looking for those really repeat kind of investigations. Or it can be in the treatment avoidance, someone who's refusing to attend appointments or just no showing without an explanation to appointments or cancelling things at the last minute. So obviously treatment avoidance is going to worsen outcomes. In sort of more advanced illness in lung cancer, I think there's sort of, you can have 14-month survival for people without depression and 6 months for people with depression. So I think really important to look at mental health outcomes here as directly affecting mortality. Also in prostate cancer, increased risk of suicide is something we really need to be paying attention to, particularly seeing as men are sort of a high risk of suicide at background as well. So that's something we definitely want to be paying attention to here. And finally, of course, that we've got really high rates of men not accessing support for mental health concerns at all. Obviously, as well, if we've got a bit of an older cohort, there can still be a lot of stigma around accessing mental health services. So in primary care, I think there's a real role for normalizing mental health treatment there. I'll just pop over to the next slide, Cami, thanks. Specific concerns for prostate cancer and for cancer here, and I think this is stuff that we can really assess for in primary care. Specific phobia stuff, so this is typically kind of blood related and claustrophobia related. So if you've got patients who have a fear of needles, a fear of blood, or fear of being in confined spaces where masks or sort of difficulty with MRIs might be really difficult, then obviously kind of be assessing for that, and just know that from a psychological perspective, these are particularly treatable conditions and something we can treat on a sort of shorter time frame. So really helping to improve compliance and just reduce the discomfort of treatment there. Other things that we're looking for here from the anxiety picture, scan anxiety. So that would be sort of pulses of anxiety as we're coming up to a PSA screening or immediately after screening, and fear of cancer recurrence for those who are in remission. This is something definitely on a spectrum. Everyone is going to be scared of cancer occurring, but where this can become really problematic and lead to that either avoidance of testing or overutilization of services. In sort of categorization, we're splitting that into illness anxiety, which really focuses more on the fear of future symptoms as opposed to somatic symptom disorder, which would be an over preoccupation with maybe minor ongoing pain or incontinence or something like that. In terms of sources of distress, these are pretty obvious ones. So mortality, obviously, concerns of death, and especially if it, maybe a guy in his 60s about to sort of retire or is looking forward to a healthy retirement, this is going to be a real blow. Particularly with prostate cancer, we've got threats to sort of identity as a man. Particularly with sexual function, but also ability to be a provider can be a really common one that's difficult for guys. And also difficulty with accepting a sick role. Again, if someone has been a provider, has been the one that people lean on, and finds it really difficult to accept that they need to ask for help, maybe a lot of kind of difficulty wound up for that. Also, obviously, as everyone's kind of been talking about tonight, some really specific burdens from treatment itself, difficulties either with biopsy, radio, surgery, kind of all of them, incontinence, erectile dysfunction, and the hormonal impact specific to ADT. Noticing that these are not just unpleasant, but they're also really threatening for a lot of guys from that idea of losing their identity. Next slide, Cami, thanks. For all of these, there are good psychological interventions that can reduce distress and improve overall functioning. So your go-tos are cognitive behavioral therapy and ACT, acceptance and commitment therapy, with mindfulness-based stuff in there as well. And also kind of just psychoeducation, normalization of treatment-related distress and supporting people with some, quick and practical strategies to kind of navigate that. Maybe, for example, relaxation strategies for someone who's got a needle phobia, so that they can go in and get that treatment and feel a bit more comfortable with that. Specifically, we can also look at managing incontinence, erectile dysfunction, and this is where the Men's Health Centre, I think, has great cross-referral options. Distress management, safety planning for suicidal ideation if that's coming up for your patients. And yeah, really focusing on exploring any barriers and sort of resistance to treatment that someone might have. Yep, I'll pop next slide, Cami. So quick kind of list of things to be looking out for in primary care. Obviously do screen for psychological distress. Your DASS is really good, which will be a normal part of a mental health care plan pathway. Looking at the hospital anxiety and distress scale is one that we often use specifically in hospital settings to reduce the confounds of, say, feeling low energy when someone's got fatigue as a part of illness. Also just normalizing that it's the normal response to have distress and adjustment issues immediately following diagnosis. In terms of screening for these specific kind of cancer-related syndromes, just ask about fear of treatment. If you know someone's got difficulty with needles or any of these kind of backgrounds, just sort of chat to them about that and make sure that they know that there's support they can get. Often I get guys who have no idea that this is even something they could be getting help with. And just be on the watch for missed appointments. I think in primary care, this is something where you guys have a lot of visibility and can sort of be supporting people who are maybe disengaging because of that anxiety. In terms of suicidal ideation, screening for suicide does not increase risk, so feel comfortable kind of going to that space. Obviously, the common ones here, we're looking for specific plans, intent to follow through on plans, access to means, and a past history of suicide attempts. And feel free, of course, to refer on if you're getting any of those positive. And then I think as well, primary care, with those sort of ongoing relationships in community, you've got a great opportunity to kind of normalize access to psychological services. And I think cancer provides a good window for guys who otherwise might not access mental health treatment to feel comfortable accessing support. So I think that's a really good opportunity to get involved and sort of suggest those referrals on for guys who are struggling. I think that's me.
Hello, everyone. My name is Peter Talbot. I'm a dietitian at the Men's Health Centre. Just going to talk about nutrition care of prostate cancer. So the patients I usually see are pre-surgery for radical prostatectomy, looking at low muscle strength or mass or malnourished and trying to keep within a healthy weight. A lot of my work is to do counselling with people with androgen deprivation therapy, looking at weight management, preservation of muscle mass and protecting bone health. And then we also deal with people having radiation or chemotherapy, dealing with the side effects and looking at strategies to get them to eat well during this time as well. Next slide, please. So just looking at androgen deprivation therapy. So the effects it has, it affects the lipid metabolism. So you can get a rise in the total cholesterol and a rise in the triglycerides quite quickly. You can get a change in glucose metabolism. You start to lose bone mass as well, leaking of calcium from the bones, and then the muscle metabolism as well. You'll start to get a fat accumulation around the stomach and around the waist, and then you're losing muscle mass as well. So all these things can lead to a form of metabolic syndrome. It can go on to lead to diabetes and cardiovascular disease, and osteoporosis and fractures and falls. Next slide, please. Looking at the diet studies on patients on ADT, unfortunately, there's limited evidence to show the effects of diet alone because most of the lifestyle interventions have been with exercise and with diet, so it's hard to separate the two. But from the studies, we've found that the three things that may be working are protein supplementation for body composition changes, using protein, calcium, and vitamin D supplementation, and also using a Mediterranean diet pattern as well. Next slide, please. So specifically for hormone therapy and looking at diet, we sort of give a tailored plan. We work with the men to try and look at their food intake and look at what's happening there. We look at spreading out the protein. We've got to make sure people have between 1.2 and 1.5 grams of protein per day, and then they need to spread out the protein through the day as well. By doing that, they'll be able to get giving enough protein to make muscle, because they're also doing exercise as prescribed by the physios as well. So it'd be things like having plenty of protein for breakfast, lunch, and dinner. And then looking at having enough calcium, 3 to 4 serves per day of dairy, having sufficient vitamin D, and getting the blood levels of vitamin D checked, reducing their alcohol intake and caffeine and salt, and exercising regularly and quit smoking. For insulin resistance, we recommend low glycemic index diets, making sure they have at least one low glycemic index food per meal, and exercising regularly and having healthy fats. And similarly with dyslipidemia, we'll do a low saturated fat diet, make sure they have good fats like avocado, olive oil, nuts, having a high fiber intake, psyllium plant sterols, nuts, oily fish, and soy protein. Next slide, please. And finally, just looking at weight reduction. So lifestyle will have an effect of about 3 to 7% on their weight. And this is sufficient to cause changes in blood glucose, triglycerides, HDL cholesterol, and their blood pressure as well. Next slide, please. I'm just looking at the green bars here. These are the results of lifestyle changes. So you can see from here, 55% of people will make significant changes to their weight. This is weight changes. So the green bars are all the people who've made lifestyle changes. So it does have still a significant effect. We can get overawed by the effects of Ozempic, Mounjaro. Mounjaro's in red and Ozempic or semaglutide's in blue. But I just wanted to remind people that lifestyle is still quite significant as well. Next slide, please. And the trouble is, when you come off these wonder drugs, you do get this rebound effect again. So after the people came off semaglutide, they regained 2/3 of their weight loss. So we still must put a lot of effort into changing our lifestyles with both exercise and food changes. And that's what my role is to emphasize all the changes they need to make in their food intake. And we work together, and it's a lot of behavioral change advice as well to help them eat a healthy Mediterranean diet. That's the end. Thank you.
Next presentation, we have our social worker, Jenny.
Hello, does everybody hear me? I'm Jenny Rigby-Knight. I'm a social worker at the Men's Health Centre. As everybody's pretty much alluded to, Dr. Andy mentioned the holistic approach we have, looking at the whole patient. So obviously, there's a team of people, trying to wrap around the patient, trying to sort of make things a little easier at this terrible time. It's obviously a very stressful time adapting to this diagnosis and treatment. Sometimes people are referred to me for something very simple. It might be accessing their super to pay for treatment. It might be, what sort of Centrelink can they be on? And I find that often opens up a whole Pandora's box. You find that people come with pre-existing chaos in their lives. And they're often very overwhelmed with the cancer diagnosis and the demands of treatment, just too overwhelmed to sort of find their way out of it. So I can help them with a lot of practical supports. It also just gives me an opportunity to sort of meet them and provide emotional support. And often people are very happy to tell their story, and they've come for something practical, but they realise they actually need something else. So I can direct people to income replacement if that's an issue. Lots of people don't seem to know that they could be on a pension or a benefit. Older people would need some sort of aged care assessment, so I can direct them to that. There is some assistance through the Cancer Council. They can get pro bono legal and financial counselling, which is obviously very expensive and out of most people's reach, but that's something that they can they can access. There's also some supportive counselling lines that they can, through the Prostate Cancer Foundation and through this Cancer Council. There's some means-tested crisis funds from the Cancer Council. And lately I seem to have got caught up in transport. A lot of people find it quite difficult to get to the centre or to get to the oncologist or to the urologist because they've got a lot of mobility issues, or they're fatigued, or they're unwell from their treatment, or poverty. There's a lot of reasons. So I've been kind of finding out what sort of community transport I can link people to, and also some of the people who live a little bit further away, say Southern Highlands or up the Central Coast. I've been sort of helping them with some of that. And obviously where there are children involved and there's a cancer diagnosis, people need some help with how to talk to their children, how to manage that, how to manage the children's distress. So there's many facets. So what could GPs do in primary care? They usually will know their patients really well at the point of diagnosis. I mean, not always, but they may know what challenges they face. So I think encouraging them that the team is there, that these services are there for them, and that it's, worth having a chat, having a conversation with me, and I can see what we might be able to pull together. We try and make things easy for people, so there's telehealth, there's phone conversations, and bundling appointments I think is helpful. So if people are unwell and they're struggling with their treatment, they can make an appointment, say, with me on the day that they're coming to see the physio or the nurse, or going next door to see the urologist. So we try to sort of make it a one-stop shop where they can come and they can see a few people at once. So that's me. Send them along. We'll see what we can nut out. We have to be quite creative about what we do to support people. Thank you.
Thank you all, and a big thank you to all our speakers and attendees. We'll spend about 5 minutes or so just going through some of the questions. If you do need to leave, that's okay. And just a reminder that the session is recorded, so you can always come back and watch the answers. So the first question is, if the first PSA is 6, then repeat within 3 months drops to 3, what is the next plan?
Were you answering? It says that Jeremy's going to answer that, but I'm happy to talk about that.
Sorry, I clicked the button in mistake. We talk about it.
Is that question referring to someone who's been treated or not treated? But assuming it's someone who hasn't been treated, if you do a PSA and it's 6, and then 3 months later it's fallen to 3, if that's within their normal age, I would think that the 6 was a spurious rise, and I would go with the 3. I don't think cancer makes your PSA go up to 6 and then fall to 3, and that's why we would always repeat a PSA within 1 to 3 months before acting on it, because we know the PSA fluctuates for so many reasons, some of which we are aware of and some of which we aren't aware of. So if it fell to 3 and that was normal for that patient and previous PSAs were more in line with the 3, I would be very happy to accept that.
Thanks, David. And is brachytherapy safer for the anterior prostate cancer compared to other focal therapies in terms of urethral protection?
I guess I can answer from the brachytherapy standpoint. I mean, brachytherapy is definitely an option for anterior. I guess brachytherapy tends to be a whole gland sort of treatment. It does carry risks to the urethra, and I guess as David mentioned, focal therapy is very quickly becoming almost a standard of care in these situations because it doesn't cause as much urethral damage as potentially brachytherapy.
Thank you. And the next one, does penile rehabilitation help to improve sexual function in the long term, or just help while the patient is taking treatment, e.g. Viagra?
It's more like a prostate cancer nurse questions. But I can say that once, let's say, after the surgery or after radiation therapy, they do return to the baseline functions. In terms of pineal, it helps, particularly with the pelvic floor exercise. That Luke, have you got some stat that you can
So
support?
it doesn't necessarily guarantee that you're going to get a faster recovery of your erections, or you're going to increase your likelihood of getting your erections back, but it can help to preserve tissue health and length of the penis more specifically. And it can help to improve sexual functioning throughout the recovery process. So, for example, like if you're using a constriction ring, but no, it doesn't necessarily quicken or increase the likelihood of erections coming back. It just helps mainly with tissue health and length. A lot of the guys who have good recovery of their erections, they tend to, the younger guys, have good baseline function and also have full nerve sparing surgery.
Thank you. And is there any evidence effect of microbiome on prostate cancer incidence and thus effect of MFT on especially anxiety and depression, as well as chemotherapy? Hopefully that makes sense.
Yes, I could try and answer that. I guess that the microbe is a very hot topic in terms of cancer in general. In terms of impacting outcome, I'm not aware specifically of evidence in the prostate cancer realm. And I guess FMT, I'm assuming you're talking to fecal transplants. I'm also not aware of their impact in terms of anxiety, depression caused by chemo.
Thank you. And for the Men's Health Clinic, do you provide any telehealth services for rural patients?
Yes, we do face-to-face, telehealth, and also phone consultation. And all our supportive services are free of charge at this point because our center is fully funded by philanthropy.
Amazing. And then in terms of sarcopenia, how useful is Sustagen, 2 scoops with milk 2 to 3 times a day?
Yes, that would be fantastic. But also just looking at their protein intake through the day. So like having egg and yogurt for breakfast and milk, meat, chicken or fish for lunch and dinner. That would also be really good to increase their protein intake and good for muscle building.
Thank you. And just another question in terms of referrals. Can you accept patients who were not treated initially by your centre?
Unfortunately, at this point in time, our model care is we only accept patients who are under the care of a St. Vincent specialist. So if you do have patient that will need a diagnostic workup, yes, then definitely refer to us. We have seen some of the patients who are referred to us by GP looking for a second opinion. That's more to do with before they have any kind of definitive treatment. But once they have definitive treatment down the track, unfortunately, we won't be able to provide our supportive services. Generally speaking, we'll refer them back to their local health district, and there will be other health services available in their local hospital oncology department.
Thanks, Cami.
I think it's something we might do it in the future, but at the moment, I just think we need to test our own resources. We didn't think we wanted to. We've only been open for a bit over a year, mind you. It's coming up to a bit longer than that now. But we didn't want to overreach without knowing that we could service the patients. So maybe in the future we would, but at the moment we just don't have the resources.
Thank you. Medical grade pump. Some of my patients, they purchased it from an adult shop and it is cheaper. Is it the same as the ones you sell in the Men's Health Clinic?
We don't actually sell any product in Men's Health
Maybe we
Clinic.
should, Cami.
we normally provide patients information with the company who make those devices. And they are medical grade, and my understanding it's around $300, and they can get some subsidy, and we do provide the letter that they need with the specialist provider that they can use it to claim it back from their private health insurance.
Thank you. And the last one is just a thank you to all the speakers, and they've asked if it's possible to get a copy of the slides. So if the speakers are happy to share those, we can send those in the post-event email. So thank you again to all the speakers and everyone for attending. Just a reminder that a survey will pop up at the end of the session, so please provide your feedback and a follow-up email will be sent tomorrow. Please visit our website for any upcoming events, and we look forward to seeing you online again soon. Thank you.
Thank you.